I guess the high-level summary is that for those of us not skilled enough to do whole life, we have aquablation. It works really well, and the learning curve is a lot shorter. All right. So these are my disclosures. All right. So just to really quickly go over, so water jets. Water jets have been around forever. They've been used in aerospace, mining, medicine, cutting, used for metal, stones, food, glass, paper, and now prostates. And we can see here how this very precise, high-powered water jet is able to remove tissue in a very systematic fashion. All right. So what are the components of the aquablation system? You have real-time image guidance. So you've got a biplanar truss proband. You've got a portion where you're doing surgical planning, and then it's robotically executed. So it's actually one of the first truly robotic procedures because the surgeon's actually out of the picture. I mean, not out of the picture, you're in the room, you've got your foot on the foot pedal, but it's essentially this robotic arm that's doing all the work. So here you can see the image of how you're doing angle planning. So you can see how you're defining you have the prostate right here, and you're defining your defect that you're going to plan out, right? And you can define the angles of it, find the junction between the transition zone and peripheral zone. In addition to that, you're also doing contour planning, where you're figuring out where the bladder neck is, where Vira montana is, and also as you put in the robotic arm, you're able to mark out where Vira montana is and other important structures like ureteral orifices. So here is a 4x speed, but I think I want you to notice the time. The resection time is usually around 3 to 4 minutes, and typically doing 2 passes. So in a matter of 8 minutes, you're removing all this tissue. You've got both the cystoscopic view and the transurethral ultrasound view, and you can see how under ultrasound you're creating a large defect within the prostate. All right. So when we look at the clinical data, we've got 3 large studies. You have the water study, which is prostates 30 to 80 grams. You have the water 2 study, which is prostates 80 to 150 grams. And you have the open water study, which is 20 to 150 grams. When you look at a meta-analysis comparing these, looking at all 4 trials, which included over 400 patients with prostate volumes between 20 to 150 grams and 1 year of follow-up, we can see that you have IPSS improvement of about 16 points, flow rates of about 20 cc's per second, quality of life improvement by 3 points, post-void residual improvement by 60 cc's, and if you look at the rates of ejaculatory dysfunction in this population, about 10%, which is a fraction of what you get with TURPs and lasers, erectile dysfunction of 0%, and incontinence of 0.5%. And if we look at the 5-year outcomes, because obviously you want to look at durability, you can see that there's a 6% retreatment rate, and this is looking at prostates at 30 to 80 grams. And this is just another view of it. Basically, this is a 5-year analysis looking at prostates 30 to 150 grams. And you can see there's a 4% retreatment rate, a 4% rate, including those restarting medications. So as you can tell, by creating this large controlled defect, you're able to get a long-term durable outcome. So this is looking at a variety of the treatments that we spoke about earlier. This is looking at the water study, TURPs, Resume, Urolift, and this is the Water 2 study. So what's notable is that the growth we've seen within BPH therapies is probably the largest between 30 to 80 grams. That's where we have the newest players in terms of novel stents, novel devices. But when you take a look at aquablation versus other therapies like TURP, you can see the retreatment rates of TURP are about 12%, Resume about 15% once you include those that restarted medication, and about 24% for Urolift, but that's not including those who just had clips removed. Those are patients who underwent just retreatment, not just removal of clips. And once you include prostates above 80 grams, the retreatment rate is slightly higher by about 2.5%, but at the same time, it's still very, very low. One of the big concerns with aquablation is that obviously a high-powered water jet may not be hemostatic, right? So initially, the trial with the Water 1 study was using a retraction device that put pressure on the prostate. Starting in about 2020, there was a concept called focal bladder neck cautery, which is a protocol which then led to a significant decline in bleeding vessels. This reduced transfusion risk to about 0.2% for this population. So basically what is focal bladder neck cautery? So when you look at the bladder neck, right, what you're doing is that you're just doing a pinpoint removal of that fluffy tissue from the aquablation. You're removing it to get down to capsule. And once you see those pinpoint bleeders and you coagulate them from 3 o'clock to 9 o'clock, you're able to actually take the effluent color and basically convert it from what could be pretty red into what is fairly clear. Once this is done, essentially the risk of transfusion, risk of blood loss decreases dramatically. So the summary of key points. So one is when we look at TURP, we know that erectile dysfunction rates are as high as 14%. Ejaculatory dysfunction rate is extremely high, approaching 90%. When we look at lasers, erectile dysfunction rates are as high as 20%. Ejaculatory dysfunction rates can be as high as 50%. But one thing to keep in mind with these resections is that there are ejaculatory sparing techniques that have been described with both bipolar TURP and lasers. And so you can reduce ejaculatory dysfunction rates with these therapies as well. With enucleation, it's high as 77%, and simple prostatectomy, again, high as 90%. So one thing, how do you achieve that ejaculatory dysfunction rate of about 10%? It's basically this idea of this butterfly clot. So what you're doing is that when you get to the paracolicular structures or where the ejaculatoris muscularis muscles are, you're basically sparing the mucosa around that area. And here we can see it via ultrasound where it's clearly very easy to mark out. And when you're passing that robotic arm and you have the ultrasound probe in, you can actually visualize where the viru is, and you can visualize where the the kissing portion of the lateral lobes are as well. So it's very easy to remove that tissue while at the same time preserving ejaculation. And this has been published basically looking at, this is a study with Kevin and Dean, looking at the risk of anejaculation post-procedure. And what we can see here is that when you have a deeper, longer cut around the viru, that leads to higher rates of anejaculation, versus when you spare that area, rates of ejaculation do drop dramatically. And again, maintenance of erectile function, again, 95%, ejaculatory dysfunction, again, 92%. So violation of these anatomic structures can lead to ejaculatory dysfunction, but that's true for a lot of the technologies, but I think aquablation is the one that allows you to have really precise control of that, because you have both ultrasound view and cystoscopic view as you're doing the procedure. You want to be careful of these anatomic structures, and when you're planning these contours, you want to make sure the cut depth doesn't exceed beyond 5 millimeters below the viru. One other thing I also want to bring, so one thing I want to bring up is that this also kind of shifts our practice a little bit, because, originally when we're talking about prostate size, a lot of the treatments that we talk about things like prostate anatomy. Is there a presence of middle lobe? Is there a high bladder neck? What's neat about the aquablation system is that you're able to basically treat the variety of prostates that are out there, all the way from 20 grams to prostates as large as 300 grams. Lastly, I just want to also talk about the fact that aquablation has started, the team has started looking at prostate cancer as well, where they've enrolled 20 patients across 3 sites in the US, looking at basically you do aquablation for the BPH, and then you do an additional hemi-resection of the area where prostate cancer is located. And I'm trying to hurry up based on my timer. So again, what's the benefit of this for potentially in prostate cancer? You have real-time image guidance, personal treatment plan. You got that robotic execution of it. Obviously, it's heat-free, and you're able to not superimpose, but you're able to use these 3D MRI image to know where the location of the lesions are for resection and removal. Thank you.